This lecture, lecture number 34, we're going to be discussing a little bit about the epidemiology of behavior disorder, that is, its incidence in various types of populations. And then what we're going to do is we're going to be taking a look at a little bit of the history of treatment, which is fascinating. And then we'll start to get into, in a general way, initially, different forms of treatment. So let's begin this by taking a look at the incidence of behavior disorder here in the United States. And we have this broken down in terms of the percentage of the U.S. population, which is here on the horizontal axis. And on the vertical axis, we have different types of disorders: depression, phobic, panic, and other anxiety disorders, substance abuse disorder, antisocial personality, schizophrenia, or similar disorders, and then lumped into all of these together into any disorder. And I think that it would be instructive to focus on this right here, because what this shows is that annually, between 40 to 50% of the American population is going to be treated for behavior disorder. Again, any given year, but that's what we're looking at. Now, American population is somewhere in the neighborhood of 370 million people, I think. So we're looking at a lot of individuals who each year are seeking help and need help. And again, I think that this is a very important graph that I want you to remember, because it says a lot, I think, about how pervasive behavior disorder really is, and that we certainly need to be more effective in terms of how we go about treating individuals suffering from behavior disorder. So again, the epidemiology of behavior disorder, we can break it down in a number of different ways in terms of this demographic variability. If you take a look at gender, typically there are more males and females in state, county, and VA hospitals. You see a higher incidence of brain syndromes, alcoholism, drug addiction, sexual deviation in males than you do in females. So again, there's a an interesting sex difference here, gender-based difference here in terms of this demographic variability. When you take a look at age, certainly another important factor. Neuroses, antisocial personalities, other personality disorders, that's something that really reaches its peak during the adolescent years. Psychotic and schizophrenia, psychotic behaviors like schizophrenia, biologically, organically based disorders like alcoholism, that peaks in middle age, and other organic syndromes, biologically based syndromes like Alzheimer's disease, for example, and other dementias, that tends to peak during old age. If you take a look at marital status, the highest rates of mental disorder are seen in separated and divorced individuals, which I've always found to be a very interesting statistic. Lowest rate seen in married men and women. I mean, this is almost an argument for getting married and staying married. So again, this is simply a correlation, though. We can't really determine cause and effect from this at all. When you take a look at social class, generally the lower the social stratum an individual is in, the higher the incidence of mental illness. And there's a real interesting relationship between, types of behavior disorder and socioeconomic class. If you take a look at high socioeconomic class, you get higher levels of neurotic-based behaviors. Take a look at low socioeconomic class and you have higher levels of psychotic-based behaviors. which again typically are considered to be more severe. So again, this social class, certainly there's some very interesting relationships here in terms of behavior disorder. When you take a look at cross-cultural variability, and this is through the lens really of cultural psychology, which is an emerging area of the field of psychology. You see mental disorder in all cultures, and even some of the most remote cultures in the world. Parts of Australia, for example, and parts of Indonesia, very remote indigenous cultures, you see mental disorder in every culture that's been examined. Now, it may be called something a little bit different. This may differ in terms of how it's interpreted from culture to culture, but as the DSM, for example, becomes more widely utilized, that we see this prevalence of mental disorder in all cultures. So indeed, very important work going on in the field of cultural psychology now, trying to document this cross-cultural variability. But I think the more of it that goes on, the more it indicates that very, very strong similarities here in terms of the incidence of disorder even in dramatically different cultures from what you would see in the East as well as in the West. Ethnic group. I don't know of any data that suggests that there are differences in the incidence of behavior disorder based upon ethnic group. I mean, there's those myths, for example, that Italians are more emotional and that the British are more reserved and in terms of their personalities. I mean, this just doesn't really hold up. And indeed, I don't know of any good data that's out there suggesting that ethnic group is a factor. What I want to do now, after taking a look at that epidemiology, is I want to talk a little bit about some of the history here, which I think is really interesting and really important for our students to have an appreciation for. So we're going to take a look at some of the historical antecedents of treating those that are suffering from behavior disorder. Certainly, medical disorders have been treated in some very primitive ways for a long time. The use of leeches, for example, to draw blood out of an individual was something that has been used for over 2,500 years. When we look at the use of what is called trepanation, in which holes were actually, cut into the skull. This is something that really goes back to prehistoric times. And again, here's some very old skulls that you see here in which, holes were cut out of the skull in order to, I guess, to release demons. I mean, that was the reasoning, the major reasoning behind this. If you take a look also during the Middle Ages, for example, it was thought that treatment for disordered behavior could be placing an individual's head in an oven and baking out these demons, that these demons would flee as a consequence of the heat that was being applied. Certainly very primitive way of treating behavior disorder. And as we go along, certainly the use of straitjackets and chains, covered bathtubs like what you see here, which are, believe it or not, are still used in some cultures, primarily in treating of psychotic patients, which in some parts of the world are called raving patients. This too was utilized and still utilized in some cultures. The utilization of the crib, which, as you can see here, this is something to restrain mentally ill patients, usually patients that are acting out, that are probably, in many cases, were individuals that were schizophrenic. Again, another, very crude way of treating those suffering from disorder. When we take a look at this device, this is called the tranquilizing chair, and this box placed on the head of an individual, and it was thought to calm them. Typically, it was used with manic patients, and it was thought to restrict blood flow to the brain. Again, while the individual is confined in a chair. Here you can see the strap here and the arms attached to the armchair of this chair. This circulating swing was also used. Again, it was thought that this high-speed rotation would actually reduce depression. And certainly various religious rites, like what you see here, exorcism, which was thought to release demons. This was part of the Catholic Church. This too was utilized, still utilized to some extent in some parts of the world, but there comes a transition point in all of this, and that transition point really was this individual that you see here, Philippe Pinel, who was a French physician who believed very strongly, and this is in the late 1700s, he believes very strongly that people who are suffering from mental illness have to be treated with compassion. So now we're seeing a very profound change that results from his beliefs and his practices. He says that, and this was the common practice at this time, that people who were mentally ill were being placed into prisons. They were incarcerated like individuals who committed crimes against society, things like murdering another individual or stealing from another individual. So they were treated in an identical manner. And what Pinel said was, this is wrong. They're deserving of compassion. They're deserving of help. So that certainly opens the door to a very different way of viewing and treating those that are suffering from behavior disorders. So when we transition to the United States and we take a look at this development, certainly there in the United States, the type of care that we saw in the 1800s was in small asylums, and it was referred to as moral care. So those small asylums, had a lot fewer patients than what we observed later on in these large psychiatric institutions. The patients engaged daily in inspirational classes and religious services. They were encouraged to work. A lot of group meetings, a lot of meetings with staff members, and again, the overall goal, as I've noted here, was to establish regular habits of self-control. And when you take a look at the success of these small asylums, one of the things that you see is that, according to the records that were maintained at this time, that 75% of individuals actually recovered, 58% never had a relapse. Now that is phenomenal in terms of those outcomes. But then something happens here in the United States, and things begin to change. And that moral care begins to change, and again, because of so many immigrants who are coming to the United States now, the population is larger. Now this quadruples the client-doctor ratio. And these small asylums now are replaced by what we call custodial care, these very, very large psychiatric hospitals. And indeed, the staffing that was done in these hospitals oftentimes was by political appointment, where the individuals that were in charge really had very little background in terms of treating individuals suffering from behavior disorder. So they're untrained, and too often they were uncaring. Studies that were done during this period of time, again, we're talking about the early 1950s, they typically showed that most patients really did nothing over the course of a typical day and received very little care, very little treatment. Indeed, what would happen is that typically staff members, when a patient was acting out, that's when they got attention, to these exhibition of these pathological symptoms. And this was something that was, if you read about and understand learning theory, I mean, one of the things that happens with a behavior that's rewarded is that it increases. And this is indeed what was happening in these institutions, that whenever a person acted out, they were given attention, and that attention essentially was strengthening those behaviors, those unwanted kinds of behaviors. So again, now we have a situation where it's largely custodial care, large psychiatric hospitals. Then something happens in the 1950s, and that, of course, is the development of drugs by the pharmaceutical industry, tranquilizers, antidepressants. Now they're becoming available, and these negative symptoms can be eliminated in many of these patients, and they become much, much easier to work with. And it was thought at this time in the 1950s that, hey, this is the answer. This is what is finally going to help us in terms of treating individuals with these various behavior disorders, and we do it by way of a pill. That estimate, that prediction obviously never came true. Drugs are only really part of the answer in terms of treatment of individuals suffering from behavior disorders. So drugs reduce symptoms, but often they don't get at the underlying causes of behavior disorders. And again, that's still true today. It's rare that we have a situation where drugs alone are going to be effective in treating a person suffering from behavior disorder. So then along in the 60s and 70s comes Max Jones and the advent of what's called the therapeutic community. Max Jones makes the observation that there's too much time is being wasted in these large institutions where patients are really only receiving maybe at best an hour therapy a day. And it's not as if these patients can't do more in terms of helping with their own therapy. They can collaborate with staff members in terms of directing their own therapy and play a more active role overall in terms of their treatment. So the goal at this time then is very simple. We want to promote these interactions with others. We want to build up confidence. And the physical changes in psychiatric hospitals were dramatic. Doors were unlocked. These individuals now are able to freely go in various parts of the institution. They started to wear their own clothing instead of institutional, almost, hospital-like, very bleak, bland kind of clothing, almost as if they were prisoners. Now that's gone. Meals were served family style. The patients are encouraged to support each other and to confront one another. And the bedrooms now take on a totally different appearance. Instead of that very bleak institutional look, now they're beginning to take on the look of a bedroom that's in a typical home. So Max Jones then and the so-called therapeutic community becomes a very important change that begins to take hold, not only in our country, but in other countries as well. Then, in the 80s and 90s and continuing on to the present, the establishment of halfway houses. Therapy is provided without isolating the patient from their home. You know, the therapy is in a home, a halfway house that's in the community that they live. And the patients can get jobs and work during the day, but then they return to the halfway home in the evening. Excuse me. So that becomes the standard in many respects for community mental health here in this country, but it too is not without its problems. The goal is to get away from these large psychiatric hospitals, and indeed that's what starts happening in the 80s and 90s here in this country. They start closing down. We start, trying to get these individuals into these community halfway houses. But it's very much a transition that is highly dependent upon the political climate and the social climate at the time. The amount of funding that is available to do this. Sadly, Republican administrations tend not to fund as much these particular strategies, whereas Democratic administrations tend to be more active and more progressive in terms of the funding of these community mental health programs and halfway houses in particular. We have, I think, this attitude of not in my neighborhood. And some of you may have experienced that in the places where you've grown up and where you've lived, where there's an idea that's put forward to a city council of the establishment of a halfway house where it must receive approval, and the city council goes through deliberations and public hearings and so on, and the people who live near that halfway home become very vocal in terms of saying, no, we don't want it here. These people are dangerous. This is not something that we want to see wandering around in our neighborhoods. That comes from ignorance. There's actually very few individuals that are diagnosed with behavior disorder that are actually a threat. Indeed, it simply comes from not being knowledgeable about what mental illness actually is, and an overemphasis upon, a few cases of individuals that are suffering from very severe mental disorder who have done great harm. So that's pretty much where we're at right now in terms of these changes that have taken place in our own society, and it's been a very interesting progression that has taken place from those early times of asylum care and then custodial care to ultimately to community mental health programs and the establishment of halfway houses. Here's as we get into therapy now, here's, I think, a very unfortunate stereotype about therapy. We have, these two individuals that are talking, and they say, I'm so proud my son visits a fancy psychiatrist 5 days a week, and all he wants to talk about is me. I mean, the typical stereotype of therapy is, I think, talk therapy. Where a psychologist or a psychiatrist meets with an individual several times, several times a week. And, it's very much the Freudian psychoanalysis, I think, that the average layperson thinks about when they think about therapy. On this slide, what you see are the three basic forms of therapy. And again, we're going to be taking a look at these. There's over 250 different types of therapy that are used today. Obviously, we can't get into each one of them, but we have, three basic approaches. What we call insight-based therapy, of which, Freudian psychoanalysis and cognitive approaches, rational motive therapy, cognitive behavior therapy, humanistic therapy, and what we call group, family, and marital therapy. These are the general insight-based therapies, which we'll be getting into. We also have what are called behavior therapies, classical conditioning, operant conditioning, observational learning. Those are the major approaches in this particular branch of therapy. And then we have biomedical, meaning biologically based therapy, psychopharmacology, electroconvulsive therapy, psychosurgery. These are, again, biologically based therapies. When you take a look at therapy, there's a number of important questions, that have to be asked of any therapy. So let's take a look at that. What's the cure rate? How many individuals are actually helped by this? How reliable is it? Does it work all the time? What are the side effects? Sometimes the side effects of a therapy can be worse than the actual negative symptoms that a mentally ill patient exhibits. How do you define cure? Is it the absence of symptoms for a month, 2 months, a year, 2 years, 3 years, 5 years? Is it, how is this assessed? Is it assessed by the evaluation of the patient that they're better? Is it assessed by the evaluation of the psychiatrist or psychologist? These are important questions, and they really need to be asked of every therapy that we look at. So, in our next lecture, we're going to be going through these various types of therapy. And again, this is not an exhaustive analysis, but it is one in which you will be seeing representative samples of various types of therapy. And again, taking a class in the study of behavior disorders certainly is something that for those of you that want to go on to psychology, that you should think about very seriously in terms of taking. So again, in our next class, we'll start taking a look at some of this therapy. We've gotten the history now, and we've taken a look a little bit at those important changes that have taken place in terms of our thinking about institutional care and what things actually look like now. Now we're going to get into individual therapies.